our team, it's universal. Yeah, it's a universal. It's a evidence based. There is a lot of concern for exam integrity. You have seen that all the questions are on posted on Google and on the various websites that are out there. So it is really not something that we are doing. Don't think that. It's pretty much like all over the country. The research and evidence says that, when we do these exam review ditto question to question, that poses a big problem with the exam integrity, right? So it is something, again, we talk a lot about, evidence-based practice and everything. So it is that this review that we are doing, that is only reviewing the concepts. This is also an evidence-based practice that we are doing, right? So it is not just like we sat down and we come up with that, let's not review the questions. No, right? So it's a whole committee, and it's research based. Yeah. Okay. So
I have a question about that. You say it's evidence-based practice to not review each question because that's good for test integrity.
yes.
But if we don't know what we're answering, what we answered wrong, then moving forward, we will always think that what we know is true. We don't know that we're thinking the wrong thing. So how is that good for our nursing practice?
Okay. Right. Okay, I understand. Thank you for the question. So the whole point of reviewing the concept is giving you a good idea of what was asked in the question and what is that you got wrong, right? After the concept review, again, if individual students, if you have questions, specific questions for us, right? Feel free to reach out to us. We will tell you that, okay, this is the reason why you got it wrong. But you'll see once we review the concept of the question that, okay, with the non-opioids, this is the things that you need to do, these are the things that you don't need to do. You will have a very good idea of what you got wrong, why you got wrong, right? We will give you rationale while talking about the concept, right? But when we say verbatim, we show you the verbatim, like all the distractors, all the answers and the question stem. We take a lot of time on writing one question, right? Now, year after year, writing the same question, spending 6 hours on one question takes a lot of time, right? So that's why it's like, all the universities are doing it, that it's a concept. Again, if you don't understand it, or if you still not sure about your answer, you reach out to us.
Like everybody's
Professor
saying,
Salau,
we don't remember how we answered the question. If it was a 50-50, you answered it one way and not the other. We don't remember how we answered it.
Okay.
Professor
Shahal, thank you for the introduction to the exam review discussion. We're going to go ahead and get started with the discussion. If you do have additional questions after we review what was put on the test, then again, we encourage you to speak with the facilitator who delivered the content. If you still need additional guidance, you can send me an email.
Professor Rivera, can you hear me?
Yes, I can hear you, Dr. Murphy.
Okay, thank you. I'm sorry, I it wasn't going through at first. Yeah, and I just wanted to add, so I understand that you may not know what you picked, but we're using this opportunity to provide you with the correct information and the information behind that so that you know why the answers were correct. So I'm going to talk about the information related to postpartum depression and the medications. One of the biggest takeaways from that about the pharmacology is the entire classification of the MAO inhibitors is the food restriction or the education that we need to give to our clients about avoiding aged meat and aged cheese because of the presence of tyramine and causing significant and dangerous hypertension for our clients. And that's one of the beautiful things about teaching concepts and the pharmacology the way that we're doing it, is to know that that is the information for an entire class of medication. And that's a critical piece of knowledge that nurses need to have, and building on the information that we talked about earlier in class with safety, is that that's some of the education that we need to make sure our patients know, and how to intervene. Or that's not the right word, but can they have cheddar cheese or should they pick American cheese? Because cheddar cheese is, so we're not saying they can't have cheese, but which one would they pick? One of the other things is about, mostly pretty classic about antidepressants, is they take a while to work. So a client who has an expectation that they're going to feel better in a week is not realistic. So again, building on what we talked about earlier today, we need to make sure that our clients know when the desired effect of a medication would be, what they would expect as far as the effect, knowledge about side effects, and then communicating with the provider if for some reason, if they've chosen not to continue the medication. What we don't want is for them to stop a medication and not tell anybody. In this instance, it would be incredibly dangerous, but it's dangerous for our clients who take antihypertensives or insulin or any other type of medication. So they have a right to stop the medication, but they should be calling the provider to tell them that they are and the why, because maybe there's further education that we could do, or maybe there's a different medication that could be substituted. And then the last thing I wanted to talk about is the concept or the thought process about, you have a client who's postpartum depression, and keeping in mind one of the components of depression is not just postpartum depression, but depression is the inability to care for self. And with a new mom, you may have the inability for not only for them to not take care of themselves, but to not take care of the baby. So it may be neglect, or it could be true, harm, violence towards the child. So the first step would be to ensure the safety of that infant as well. A test-taking strategy is, if they all kind of seem right, ask yourself if you could only do one of them, what is most important? So if I could only do one, I would be ensuring the safety of the infant. Okay, so that's all for me. I believe Professor Shalal is next.
Right. Yeah. Thank you, Dr. Murphy. And so reviewing the concepts of pain, the first thing is that you have to make sure that you are following age-appropriate non-pharmacological pain management. For example, if you have an infant, you are going to give them a pacifier. If you have a toddler, you can give them a toy, right? For an adult, you're going to use guided imagery or meditation. It has to be age appropriate. So always look for that lifespan consideration when answering questions. For the over-the-counter pain medications, you need to make sure that patient cannot take it as long as they want. They can just take it for so long, and then after that, if they're not getting the pain relief, they have to go to their provider to have them prescribe some type of opioids. Opioids and non-opioids, as we discussed, it can be taken together. Right. And the other concept is that we talked in the lecture as well. If there is an extended release tablet, which is also called a sustained release opioid medication, and it is scheduled for, say, every 8 hours, every 12 hours, you need to make sure that you administer it as ordered. You are not going to administer it as the patient requested, or you are not going to not give it just because you are worried that patient will get addicted to that. And the extended release medications are to be given as ordered, as long as patient is not going into respiratory depression or they are totally unstable, so that we cannot give it. And other thing is for pain, the only key assessment that you can do for the pain level so that it doesn't go to a severe level where it's hard to manage is to use the pain scale consistently. You have to make sure that every hour you are going into the room, hourly rounding, you need to make sure. Yeah, and when we say consistently, it's not hard and fast rule that it's every hour. For example, if you're in PECU right after the surgery, if depending on the anesthesia, patient did not have a block, you're going to assess the pain every 15 minutes, right? And on a medical unit where patient is relatively stable, you are going to do it every 4 hours. Every 4 hours is the limit, right? Every 4 hours we need to assess the pain. So one thing that is the key assessment is that doing your OPQRST that we talked about, a complete pain assessment, so that patient's pain is not now 10 out of 10 and it's so hard to manage it. These are all the concepts that I wanted to talk about. Yeah, thank you. And then is, I think, Professor Faherty. She is going to talk about the concept.
Yes, good afternoon. So I'm going to be discussing a few of the questions that fell under the concept of teamwork and collaboration, with a focus on interprofessional healthcare team members and referrals. So you might remember reading something about case manager and a number of different types of clients, and how to prioritize those. And you'll remember from our discussion that we talked about how the prioritization of the case manager differs from that of the nurse. So if the case manager is presented with a caseload of patients, they will prioritize those that are more likely to need more extensive planning. For example, and we had mentioned this in class, women, at-risk women, pregnant women, children with congenital conditions, clients with behavioral and mental health problems, older adults who have chronic conditions. And of course, knowing this, you would have chosen the client with the chronic illness with the highest risk. And we had discussed the ability to do that. You also might remember having a question about a family that needed resources at home, as a nurse, and you were trying to advocate for that. And we had, of course, discussed in class the importance of interprofessional referrals within the concept of teamwork and collaboration and the nurse's role in identifying community and government agencies for the benefit and support of the family. And so, of course, if you remember and you understood that, you would have chosen the solution that would reflect your understanding of the nurse's role in interprofessional collaboration and referrals. There was also a question that you might remember reading a patient that had was recovering from a fall, and there was a number of priorities listed about that patient. Okay, and you would we had gone over a number of interprofessional team members, and we had discussed what the roles and responsibility of those team members were. And of course, it's important as as a nurse to know and identify the roles within the concept of teamwork and collaboration, and knowing that you should have been able to critically think through that problem list and identified which interprofessional team member you would have wanted as part of that care of plan of care. Lastly, it was actually a skills question that we had reviewed. It was basically one of those questions that asks you what to do first. And I can only say to you that when a question asks you what you would do first, please take each answer separately and ask yourself why that answer might be true or false. Make sure you read each one, because you might convince yourself that that first one is true because you can argue it as such to yourself. But if you continue, you might find an answer that is even more true. And that is why nursing questions are different, different than standardized tests that you might be used to. And I suspect, honestly, for those of you who might have gotten that wrong, that might have not been the case, that you didn't continue down. And I think that's all for me.
Thank you, for Professor Shaharity. I'm sorry, Professor Faherty. I combined you and Professor Shahal.
Can I also just say, Maribel, before we continue, can you guys all please hold those comments till the end, and you could certainly reach out to us, at the end via email, but please pause on the comments on the side. Thank you.
All right, Dr. Rivera-Smith, I am going to be reviewing the antepartum, postpartum, and intrapartum part of the exam. And of course, there was a very big part of that. So starting with antepartum, we all know, and it was discussed and mentioned and identified, that the client goes to the doctor's visit usually on a monthly basis. Fundal height is important because we want to make sure that the fetus is growing appropriately, that there might not be any potential complications that are identified. So if you do have a client that presents to the doctor's office for an antenatal visit, and let's say she's 18 weeks or 15 weeks, that the fundal height should pretty much correlate to what that fundal height measurement, what the weeks of gestation is. If there's a discrepancy of maybe 1 or 2 weeks, they'll monitor it, but anything beyond that should definitely be a site for concern, and further evaluation is necessary. So that fundal height should correlate to whatever week's gestation that client is. And how do you determine week's gestation? Week's gestation is determined and identified by Nagel's rule, right? There was examples that were cited in class. Nagel's rule, you have -3 months plus 7 days, so that if you're given a particular last menstrual period, if those menstrual periods are normal, you should be able to determine what that client's due date is based on Nagel's rule. Big piece of the antepartum discussion was also normal occurrences and discussion about hormones, those pregnancy hormones, estrogen, progesterone, and what they cause. And we even had an at-length discussion related to HCG. Recognizing estrogen, an important component, it does spike, right, mid-pregnancy there, and understanding what do those hormones do. So recognizing that marks, the chlasma, right, those brown marks that are seen with pregnancy, like the linea nigra, all of that, as then the end of pregnancy, those hormones levels go down, that things will return to normal. The only thing we identified really doesn't truly go away is those stretch marks, the striae gravidarum. But anything hormone related, as the pregnancy subsides, those hormone levels drop, things will go down. So you need to have an understanding of the terminology that's associated with what's going to be found during pregnancy. Again, we give you the information in detail and normal parameters. What you then need to do is apply that information in detail to how you would see it in the clinical environment. What is your client going to be telling you? You have to understand that level of detail in order to, number one, appropriately provide information guidance to your client, but to demonstrate that you truly do understand the material. Safety, very big important feature related to antepartum, right? You have the woman who's growing, center of gravity changes. So important teaching that needs to be done. What should be done? The use of non-skid pads, getting up slowly. We had discussion regarding, the hypotension, supine hypotension, what should be done, whether things should be introduced intravaginally during that pregnant period, not sitting in any hot tubs. Those extreme heat, evidence-based has demonstrated that they can potentially cause birth defects. So reading each distractor to determine, is this true or not, to be able to identify your correct answer. Then we had, now intrapartum, you have that client that is in labor or getting ready to go to labor. There was discussion regarding the stations, whether that fetus is engaged, and what does it mean if that fetus is engaged? That means that presenting part is at the ischial spines or tuberosities. Anything below those ischial spines, +1, +2, +4, anything above, that means that fetus is not engaged, and that fetus would be at the minus station. There were handouts on it. There was also a separate video presentation that was put on Blackboard for that as well. The different stages of labor, right? The dilatation phase, which is stage 1, what's happening there? Mom needs to be completely fully dilated before she can then start working into that stage 2, which is then expulsion of the fetus. So she has to be fully dilated before she should be pushing because if there is any cervix, even if it's a little lip of a cervix, it can potentially cause harm or danger to mom. It can cause cervical lacerations. So there we have several concepts that are identified, not only reproduction and intrapartum, but you have safety as well. If mom is less than fully dilated, she should not be pushing because she can cause cervical injuries to herself. Getting that cervix ready for labor. We spoke about the Bishop's score and induction, right? And before an induction, making sure that that cervix is nice and ripe, right? Like that fruit, we need that cervix to be ripe in order to be dilated. And if she's being induced, well, what are some factors to help with that cervical ripening to get that cervix ready? And that would be your prostaglandins that are utilized to help with that cervical ripening. Other factors that help with the stimulation and augmentation of labor, not only related to the use of oxytocin, but natural things that can be done, such as rupturing of the bag of water, right? Or that amniotomy. What is the main priority after that amniotomy or mom's bag of water is ruptured is you need to make sure that you monitor that fetal well-being. How is that fetus doing now that primary protective mechanism has been ruptured or broken? Also want to make sure that with that fetal monitoring, that the cord didn't come through with that gush of fluid that might be seen. And the best way and only way to do that is by monitoring that fetal heart rate for a good full minute prior to anything else, right? Prior to any other intervention, such as changing the pad, because now she's going to be drenched and soaked after each contraction. You want to make sure that that fetal heart rate is monitored. Yes, it is important to note the color of the amniotic fluid, especially if mom is post dates, right? At 41 weeks, you want to make sure that there's no meconium, because the later that fetus is in gestation, the higher the probability is of that. But your first priority is you're assessing that fetal heart rate. Let's see. Oxytocin, mentioned oxytocin for the induction of labor, the importance of safety. If mom has contractions that are occurring too frequently, and there is information and detail as far as what is a reassuring pattern, what is a not reassuring pattern. And the main concern with contractions occurring too frequently is that it's going to cause fetal compromise, right? If that uterus is not relaxing, which allows perfusion of blood and oxygen, then that can affect fetal well-being. And you're going to see it with decelerations and decrease in heart rate. So if mom is being induced with oxytocin and those contractions are occurring too frequent, and that's every minute and a half, those are frequent contractions. And if they're lasting a minute and a half, then there's no break for that fetus, right? So the first and primary thing that the nurse needs to do is shut off that oxytocin, shut off those factors that is causing the hyperstimulation of the uterus. Yes, you need to call the provider, but calling the provider before shutting off that oxytocin is not going to stop that hyperstimulation of the uterus. You stop the oxytocin, you monitor fetal well-being, and you contact the provider and you let them know what your interventions were based on the situation that was happening. So hyperstimulation oxytocin is being used, you have to shut that oxytocin off. Fetal well-being, mentioned and discussed. There was a lot of information, examples presented, but priority is understanding early decelerations are expected as labor progresses, because that fetal head is moving down the birth canal. There is going to be some head compression with each of the contractions. Most important thing to identify is that at the end of the contraction, that fetal heart rate is going to go back to baseline, right? So that's expected, that's normal. You're going to continue to monitor to make sure that there is no further fetal compromise. But if you have fetal decelerations that mirror a contraction pattern, which means fetal heart rate is going down as the contraction goes up, and the fetal heart rate returns as the contraction goes down, that's a normal and expected finding. There's no need to administer oxygen position on the left side if that fetal heart rate returns back to baseline. There's no further decelerations. Immediately postpartum now, lochia, there's a particular pattern of lochia. I do encourage you to review information in detail. For example, that bubble assessment that was had a whole full day of postpartum assessment, taking care of mom and baby. The rubra, serosa, and alba, and when they typically occur, immediately first few days, you're going to have rubra, intermediate, after 10 days, more or less, you're going to have that serosa, and then the alba thereafter. It is important to review that information in detail because you are going to see this content again as you go to labor and delivery, for those of you that have not done that yet, and you'll see it in application. But you have to be aware of the details, so when you do need to go take care of your client, that you understand what you're seeing is either normal or not normal, so that a further intervention is then needed. So that mom who's delivering her first child, her fundus, the top of the uterus, should be at the umbilicus, right? So reading the entire question, if it's a first child, that's where you're going to expect immediately after delivery for the first 24 hours. It then goes down 1 finger breath or space a day, which is essentially 1 centimeter per day, every day thereafter, until the uterus totally goes back into the pelvic cavity where it is no longer palpable. So first child is important because if it's someone's second or third child, it may not be uncommon for that fundus to be maybe 1 or 2 above the umbilicus, because now her uterus is used to being overdistended. So it needs to work a little bit harder to get back down to its pre-pregnant state. But first time mom, 12 hours after delivery, that fundus should be nice and firm and at the umbilicus. Fundus firm at the firm is a key word because a boggy uterus is going to precipitate increased lochia, increased bleeding, which can lead to a hemorrhage. So a boggy uterus is just that soft. We know that a displaced uterus and soft, which a full bladder can cause, is going to lead to increased bleeding, lochia, or potentially hemorrhage. But if you do have a fundus that is nice and firm, it is at the umbilicus, right? And you still see some trickling or bleeding noted, especially it's not serous, it's not mixed with blood and body fluid, but just bloody drainage. Then you have to think and identify there's something else going on here that's not uterus related, because the uterus is where it should be at the umbilicus. It's nice and firm, but I still see some trickling of blood. That's where you then think, well, did she push too early? And maybe there might be a cervical laceration or a perineal laceration. So that's where you have to start thinking based on the clues and description from what is presented within the question. Breastfeeding, we know that colostrum, that initial milk, which is not even milk, but it's filled with antibodies, which provides that passive immunity from mom to baby. And that's the importance of trying to encourage breastfeeding, if at least for the initial 2 weeks, so that that newborn can receive that colostrum to provide that passive immunity. Now, postpartum care, postpartum and continuing, we mentioned that a temperature, low-grade temperature up to 100.4 is considered normal for that postpartum mom within the first 24 hours, because mom just worked really hard. She may be dehydrated. Her body is trying to reacclimate. There's a lot of hemodynamic changes going on there. So a temperature of up to 100.4 for the first 24 hours, that's normal and expected. Beyond that, any increase in temperature of 100.4 above 100.4, that needs further evaluation. So that a temperature of 100.8 after the first 24 hours, that definitely needs further assessment. White blood cell count, we know and have identified it's not abnormal to have an increased white blood cell count, even above 15,000 initially postpartum, because that woman's body is, again, going through a lot of changes. That's what I have as far as my content. If you do have any further questions or concerns, please do not hesitate to email me or send me a course message.
Hi, this is Professor Mobilio, and I'm going to talk about patient education. When we start thinking about a patient going to surgery, before or after the surgery, if a patient is nauseous, we want to give them an antiemetic. So an antiemetic such as metoclopramide, which is Reglan, or ondansetron, which is Zofran. So those are two that you're familiar with. We would not want to give them fentanyl. We would not want to give them Tylenol, and we would not want to give them diazepam. So we want to give them an antiemetic. When we're preparing a client for surgery, there's many nursing interventions that we need to do. One of the priority interventions is to determine what the client knows about the surgery. We want to do an assessment and figure out what do they know about the surgery, because if they do not know very much, this is their first time they've ever had surgery, their first time in the hospital, or maybe they've had it many times. If this is their first time, if they're very nervous about the surgery, we may need to provide more patient education. So we want to know if they've ever had the surgery before, if they've ever had surgery. And then, of course, how have they done with it? Because maybe there's some serious concerns on that end as to how they've handled the surgery as far as what happened to them. Perhaps they got a DVT clot during the surgery. So that's something that we need to know. We also want to ensure safety. So what type of things are we going to do for the patient? Our nursing interventions are going to be things like identifying the patient. We always want to ask them and identify their name and date of birth. We want to check for allergies. We want to review their home medications. And we also want to verify that it's the correct procedure, making sure that all those things are in check. If a support person is present, that is often very helpful. And there's a little bit of I could see where it could be a little conflicting of, do we select, a support person? Is that considered something for safety? So what we decided was, we reviewed that many times, and we decided that if you chose that distractor, that a support person is present for safety, we gave credit for both answers. If you chose it or you did not choose it, we gave credit for both. You got it right. Okay, laparoscopic surgery. You want to inform the client about a few things. You want to let them, about many things actually, but one of the things, and some of your choices were how long the surgery will take. Always good to know. Is it 2 hours, 4 hours, 10 hours? What clothing needs to be worn? Is it going to be something in the abdominal area and they need to wear sweatpants or something very loose? Wound care. Are they going to need wound care, and what type of dressing is it going to be? What type of interventions? Who needs to do the wound care? So we want to be instructing them on wound care. Pain control information. We want to be telling them about that, and we want to also let them know if they need a ride home, which most procedures, if you're having any type of anesthesia, you need a ride home. Knee replacement, knee arthroscopy surgery. The nurse will review the medications for pain control. And they're also going to ambulate the client as soon as possible. There's no need to wait for physical therapy only. Physical therapy today, they see the clients that pretty much cannot get out of bed. If there's a problem, they will see that client. For the most part, nurses work with the physical therapist in ambulating our patients on a regular basis. And someone who has knee surgery replacement, yes, it is an orthopedic procedure, but we do not wait for physical therapy. There's no need to wait and advance the diet slowly. This is a procedure that does not involve the abdomen, and they're on a regular diet almost immediately after surgery. And please, please, please do not place a pillow under the affected knee of a knee replacement patient. Please do not do that. Discharge teaching for knee replacement surgeries. We want to report a client that has increased redness, increased pain, increased swelling. So anything that is not getting better, if it's looking worse, if it's, an increase in that redness and swelling and pain, that could be an indication of a problem, possible infection or a problem. So we want to, in that situation, report that to the provider. Once again, we do not want to place a pillow under the knee to reduce the swelling. And we do want to elevate the leg for a knee replacement procedure. Elevate it, we want to keep it straight. And by elevating it, that is going to reduce the swelling, not the pillow. Blood transfusions. If a client has a blood transfusion, the hemoglobin, hematocrit are usually low, obviously. And once they receive 1 unit of packed red blood cells, we can anticipate that both levels are going to go up. So how much are they going to go up by? The hemoglobin is going to increase by about 1 gram per deciliter. And the hematocrit is going to go up about 3%. So it's 1 gram per deciliter and 3% on the hematocrit. And that's all I have for patient education. Thank you.
Okay, and I believe I'm last. And I covered the concepts of surgical incisions, integrity, surgical tissue integrity. I also covered for the lab days surgical assessment and tube feedings. So one of the concepts that is important to know is what is going to be abnormal, what do we need to report when we see. And this is just building upon the concept of, tissue integrity from last semester. When we have a person who has skin that is edematous, warm, with purulent drainage, we're going to be suspecting that there would be an infection that would be occurring. And one of the clinical manifestations that would confirm or warrant attention would be elevated white blood cell count.
We lost you.
Do you hear me now?
Yes.
Okay. All right. So if the person, how far do you hear me? About the surgical incision, if it's red, warm, purulent drainage, we're going to be looking for signs and symptoms of infection.
Yes, we heard that.
You heard that? Okay. All right. So the white blood cell count would be something that would be concerning if it's elevated. We would expect a person to have a slight temperature, but we want to make sure that it's, if it's less than 100.4, it's not going to be alarming. Typically, our patients have a low-grade temp initially with a stress response. And we would expect that there to be pain. So one of the things that would be consistent with an infection would be the white blood cell count. When you talk about delayed healing, we talked about wounds that people might have some trouble with healing after surgery, some of the risk factors. Some of the medications, such as corticosteroids, will even make healing more prolonged. It would be something that would be contraindicated to give to a patient who already has delayed healing. There might be some confusion about if a patient has diabetes and they also have delayed healing, but we are going to be using insulin to have tighter control of the blood sugar. So we wouldn't want to withhold any insulin, and the other medications that were there were appropriate and safe to be giving. So the glucocorticoid is something that you would not want to be given. Other concepts with the surgical assessment, we're building upon other concepts that we've already talked about, especially during surgery. Fluid balance is going to be very big, fluid volume deficit or fluid volume overload. So you can have both in a patient who is immediately post-op. So you want to be familiar with the signs and symptoms. What is going to tell me that this patient has been NPO too long, didn't get enough of IV fluids, or they lost too much blood? So the keys that were important in looking in the question and making sure that you interpreted the findings that were listed would help guide you to know if the patient was having not enough or too much fluid. And one question, the patient had blood loss and had vital signs that were indicative that the patient was experiencing a fluid volume deficit. And when you think about the appropriate intervention, we want to give a patient more fluid when they are behind. In contrary, when your patient has had too much fluid and we start to see signs and symptoms of fluid volume overload, such as jugular vein distension, and shortness of breath, we are going to anticipate that the patient is having overload. And the interventions that would be important would be to listen to the lungs. And what are we anticipating that we're going to hear? Is going to be fine crackles that would indicate that the patient was having some overload. Note that when a person is having some shortness of breath or they're having atelectasis, that's when we want to use the incentive spirometer. But that incentive spirometer is not going to open not going to.
We lost you again.
Can you hear me now?
Yes.
Okay. So did you
You
hear
ended
about
right
the
at the
overload?
incentive spirometer part. You ended
Incentive,
at the
okay.
incentive spirometer.
The incentive spirometer is going to be useful in which type of patients? Are patients who have been on bed rest, who are not taking great deep breaths. So that would not be a choice or something that would be helpful in our patient that has had fluid volume overload. Okay. It's so important when you are taking care of a patient initially after surgery that we monitor for what? Bleeding. We would expect that a patient is going to have some bleeding. We've cut the skin. So we would expect that there should be some bleeding on the dressing. When it's the primary dressing, the surgeon usually wants to take down the first dressing and look. So when we have a moderate amount of bleeding, we are going to turn around and reinforce it. We can let the provider know, but the first thing that we want to do is to make sure we reinforce the dressing. So a lot of the questions that were there were based on what would you do first. And whenever you can see that a first or a priority, you're going to know that the other distractors that you have are going to be indicating that those are correct, but we need to pick the most important one. Okay. Just as if we had a patient who had a wound infection, a wound infection, and we suspect that we needed to take a specimen from it, you have to think about what are the steps in which we are going to do. And the steps would be that we have to make sure that we are cleaning the wound first with normal saline prior to obtaining a culture. Because just as if we took a urine culture with urine that hasn't been, midstream or the patient didn't wipe correctly, we're going to get a contaminated specimen. So are we going to change the dressing and do a wound culture? Yes, but you have to think about the steps in which you need to do. And I think there was a question that saying we don't touch the wound. when you reinforce the dressing, you are just adding on top of the dressing. You're not taking it down and you're not changing it until the healthcare provider sees it. Okay. Other question I believe I had was on making sure that teaching is effective about the wound. And when you are going to have a patient that's going to be going home and taking care of themselves, you want to make sure that they know how to take care of that surgical incision, knowing that they need to have more nutrients. When you have open skin, correct, that's your skin is your body's normal defense. It keeps all of the germs out. So when you have an open area, they're not going to want to be submerging in a bath. So it might have to stay covered until they see the surgeon, or sometimes they are allowed to, take a shower where the water may be running down. But that would be at the discretion of the provider and depending upon the area in which the incision is. Reporting redness, swelling, edema is important to note, and making sure that the patient does contact the provider if they do see any abnormal findings. And I believe the last question I had was on nasogastric tubes and tube feeding. Principles about tube feeding are, you want to make sure that we are giving the feeding to the patient safely, not too fast. We want to make sure that the head of the bed remains up while the infusion is going. And if we have to give a medication that is given on an that's to be given on the empty stomach, we want to make sure that that stomach is empty first. Okay. And how we would do that would be by holding the tube feeding for an hour before and an hour after. If we just held the tube feeding for the first hour and then immediately started, the medication would be interacting with the food after that. So we want to make sure we're holding it before and after. And it's important to know that when we have medications that need to be given on an empty stomach, that we take into consideration how long that patient would be without food for the day. So that way we can ensure that they're receiving adequate nutrition. Okay, and as Dr. Rivera-Smith said, if there's any questions that you didn't understand the material, I am available. I'm also holding a study session on Monday. The time is posted in the study session thread, and there has been a study session in Collaborate that has been created. So you're welcome to join. If anybody wants to come in and review discussions on concepts, theories that we're talking in class, I would be happy to help you out. And help you study, but I do ask that students come prepared with things that they are unfamiliar with, as I'm not going to be reteaching the content.
Thank you, Professor Bish. All right, as indicated, if you have any questions regarding any of the content, do reach out to the facilitator that delivered that information or detail for further review. And if you have any questions beyond that, send me an email. Let me know what's going on.
Thank you, everyone, for your time.
Thank you, everyone.
Thank you. Have a great day.
Thanks.